note. Thanks for that. We'll start on a high note with an advocacy or a call to mental health advocacy by Dr. Nancy Ngumbao. Dr. Ngumbao is a lead medical officer and research scientist in the Research and Programs Department here at Kenyatta National Hospital. Dr. Ngumbao has conducted several implementation science trials, studies, and audits to aid in improving the quality of healthcare services delivered to the population and facilitate policy development. Over the past 5 years, her primary research focus has been on HIV prevention among pregnant and postpartum women, particularly looking at how to deliver PrEP to this population. Well, welcome, Dr. Ngumbao. I think you can go ahead and give your presentation.
Thank you so much, Dr. Karingo Agnes. Good morning, good evening, everyone. Just give me 1 second to share my screen, and then I can begin. I hope you can see my screen. So I formed the preamble for this presentation on mental health advocacy, and then we'll cascade and my colleagues will speak about this in the context of adolescents and this in the context of children. And so I'll just begin by giving a preamble and talking in general about mental health advocacy. So when we are talking about mental health advocacy, what do we mean? This is a concept that has been misunderstood and unappreciated. And a critical review has actually demonstrated that this concept, we say mental health advocacy, but when asked, what are you doing, or what does this mean, or how do we quantify outcomes from a mental health advocacy aspect? These are aspects that are missing. So we just go through these aspects and try and see whether we can answer these questions. I think the biggest question is, why mental health advocacy? Why is this an important topic? Why are we all talking about it now? And we all know that mental health is a global public good. So it's relevant to sustainable development in all countries, and it's actually been put within the Sustainable Development Goals because it affects the well-being, not just physical well-being, but even financial. But it's very broad and affects the well-being of people and relevant to the sustainable development in all countries. Mental health advocacy is particularly critical because mental health problems exist along a continuum. So we have people who have mild mental health problems, and this goes on to severe and debilitating mental health conditions. There's some that are acute, some that are chronic. So it exists within a continuum. And also it is critical because it is a unique product of social and environmental influences throughout the life cycle. So depending on the social and environmental influences in different settings, mental health problems present differently. And that's why mental health advocacy is critical, because it is also unique in how it is done in the different settings. We all know that mental health is a fundamental human right for all people. And because it is a fundamental human right, it exists along a continuum and is a unique product of these influences. It requires a multisectoral approach, a rights-based multisectoral approach. Okay, so when we're talking about mental health advocacy, the question that we need to ask is, what's the target? Fine, we have said that the mental health is for public good. We've said it's needed for sustainable development. But then what is the target for this? And I'll just quote the Global Mental Health Advocacy Roadmap that just says, we want a world in which everyone, everywhere, has someone and somewhere to turn to in support of their mental health and well-being. So that is what we want. So the target is everyone and everywhere. But when we're talking about mental health advocacy, then our target is engagement with various levels of people. So the first one is engagement with decision makers. And these are the policy makers, the funders, the community leaders. And over I think the last couple of years, we are seeing how decision makers are able to shift how we are doing things and how things are going. We also want to engage with influencers. And what do we mean by influencers? When I'm talking about influencers, I mean healthcare workers, like the people who serve as the gatekeepers for this. So healthcare workers. We're also talking about the media. We're talking about researchers. We are talking about organizations. We'll also include people on TikTok, Instagram in this, which us as scientists don't want to think about, but those form part of the influencers. And the goal for engagement with these people is for positive mental health outcomes for everyone. And again, back to the global mental health advocacy roadmap, a world where everyone everywhere has someone and somewhere to turn to. So we want the positive mental health outcomes for individuals. We also want improvement in policy, legislation, and service development, and increase in political and financial support for mental health. I think once we see it in those levels, from an individual policy and legislation, financial support, I think we will have achieved when we are talking about mental health advocacy. But then we've talked about the why and who we are targeting. But then what are the gaps that exist when it comes to mental health advocacy? So if I am to ask everyone who has joined this webinar, what they understand as the definition of mental health advocacy, we will find that there's no cohesive operationalization of the definitions of advocacy. It's a fragmented picture. Everyone would understand it very differently. When you're talking about advocacy, someone would think policy, someone would think having demonstrations on the street. So what's the cohesive operationalization of advocacy? And most of the time when we think about advocacy, we see it as a dirty word. We see it as a scapegoat and a source of blame when all efforts fail. So when our health systems fail in terms of delivering mental health services, we now talk about mental health advocacy. We need to advocate. It's seen as a scapegoat, a source of blame. And then there's no tangible target for it. And then the other gap is the underlying processes and mechanisms for mental health advocacy remain elusive. So we don't know, so what is the mechanism of doing mental health advocacy? We want to focus on the outcomes, but research doesn't focus on the mechanisms. And then also we omit the lived experiences and the voices of the people who are marginalized and have these mental health problems. So as I've said, there are several gaps when we are thinking about mental health advocacy. So there's need for research to solidify foundational knowledge about the definition and the processes of advocacy, so that it is very clear we address these gaps when we're talking about mental health advocacy. So now that we've said that there are gaps, we've talked about the importance of mental health advocacy, we've gone through the target, we've seen what the gaps are. To seal these gaps, then we need to understand the drivers of mental health advocacy. And I'll talk briefly about three aspects, and these are legitimacy, which is the invisible driver shaping action. I'll talk about context, and I'll also talk about timing. Okay, so legitimacy. When you're thinking about legitimacy, and that word is said without the words on the slide, the first thing that pops in my mind is it legal? Is it worthy to support? What is the collective action about it? And there are two levels of legitimacy I want us to think about. So when we talk when we're thinking legitimacy, and as I'd said, when we're thinking mental health advocacy, we think it is for someone else. But then there's internal and external legitimacy. So in terms of internal legitimacy, do we shift the responsibility of mental health advocacy? How do we strengthen the system as advocates? Because the change begins with us. So what do we do? How do we listen to the lived experience and drive community-centered solutions? And then now we can think about the external legitimacy, which is the wider communities and the state, and issues of stigma and negative narratives about mental health illnesses. There's also a poor understanding of mental health, particularly in our context, and the lack of prioritization of implementation of the mental health policy. So the question I want to pose to each of us is, how do we create internal and external legitimacy? How does this shift from being something someone does to what I am thinking about? And then we have the context. And this determines how advocacy efforts and goals come to life and evolve. So we have the proximal context in the spaces we are in, whether you're in the community, whether you're in the dispensary, the health centers, the primary healthcare system, the referral facilities, the national tertiary facility. How should the advocacy efforts operate in such areas? What do we want to see in our proximal context? Do we want to see diversification of care? Do we want to see community-based care? What do we want to see? And then now we think about the distal context. That's the broader social, political, economic, and historical community or the country. And I picked this from the Nation newspaper for Kenya. And so this is the context as which, when we are thinking about mental health illnesses, mental health problems, and this context is there. So it shapes how we change, how change might be pushed for, received, or operates. We can see how big a problem we have when it comes to mental health problems. But then in the distal contexts, how does this information shape how our advocacy efforts go? And then lastly, I'll talk about the timing. And when we're thinking about mental health advocacy, timing is important because it helps to identify and leverage key opportunities to drive significant change. It focuses the shift, or it catapults outcomes and causing a change in possibilities. I'm sharing a picture of what happened recently, where it was passed that attempted suicide is not a crime. And now at this point, have we done something with that information? Have we taken advantage of that timing? So when we're talking about timing, we talk about the external timing, which helps us in change, like the changes in policy and legislation. So initially, suicide was a crime. Now it's not a crime. So it provides a unique opportunity for civic engagement and broader discussions, and provides ability for advocates to leverage for more power. So that tends to be a bit passive, the external timing, waiting for something to happen. But then we have created timing, which is proactive, where we are creating new opportunities for engagement. So as I finish, in summary, the question that I have for all of us is, what are we doing when we're talking about mental health advocacy? How do we approach the study of advocacy in research? What should that model be for advocacy, particularly in our setup? Should it be from the community and service user led versus top down, or should we wait for the government to implement it? How do we give a voice to the people with lived experiences, and how do we engage different groups of people in the advocacy process? What should the advocacy action be? So I think, in summary, the bigger question I have is, how do we, as individuals, as people in the communities, as citizens in different countries, how do we move the work of mental health advocacy? Thank you very much. That is the preamble for this session. So I think I'll hand over to my colleague, Dr. Anna Lassen. Now she'll be taking us through perinatal depression, engagement, and child social emotional development, and just talking about mental health in the space of pregnancy, postpartum. A brief introduction. Dr. Anna Lassen is an epidemiologist, currently acting assistant professor at the University of Washington Medicine Department of Psychiatry and Behavioral Services. Lassen's research focuses on perinatal mental health and linked infant-child outcomes, particularly among populations at high risk for HIV and among women living with HIV. Dr. Anna Lassen, take it away.
Thank you, Dr. Nancy. Great introduction. Let me just share my screen. Great. So on behalf of my colleagues at Kenyatta National Hospital and University of Washington, I'm going to talk about our work on perinatal depression, maternal child engagement, and child social emotional development among a mother-child cohort in Kenya. So globally, depression in the perinatal period is associated with long-lasting consequences. Sorry, one second, let me just hide some things so that I can see. Okay, that's better. Is associated with long-lasting consequences for a range of adverse mother-child outcomes. And perinatal depression is more common in low and middle income countries than and in the African region compared to higher income countries. This region has opportunities for gains in early childhood development, and there's evidence from high resource settings that supports the relationship between maternal mental distress and child social emotional delay with a proposed mechanism through low mother-child engagement. However, there have been few studies that have longitudinally evaluated relationships between perinatal mental health and child development in Africa. So to inform early child development programs in East Africa, we evaluated extent of mother-child engagement and risk of child social emotional delay at multiple time points in early childhood. And we also explored relationships between perinatal mental health and later mother-child behavioral engagement, as well as the impact on child social emotional development. So this longitudinal analysis utilized data from the PRIMA-X study, which is an extension of the PrEP implementation for mothers in antenatal care study. This is an ongoing longitudinal observational safety evaluation of pre-exposure prophylaxis for HIV prevention used during and after pregnancy. And women who were HIV negative, age 15 years or older, and receiving maternal child health services at a study site were eligible to participate. Mother-child dyads were followed up to 60 months after birth, and we collected information about demographics, pregnancy history, partner characteristics, psychosocial factors, and mother-child engagement activities, as well as child social emotional development. So therefore, the study included a range of serially collected psychosocial assessments among mothers and children. We used the 10-item Center for Epidemiologic Studies depression scale to evaluate moderate to severe depressive symptoms anytime in the perinatal period from pregnancy through 12 months postpartum. But actually for today's analysis, we're just focusing on depression during pregnancy. And we used the UNICEF Multiple Indicator Cluster Survey, the child development items, to evaluate mother-child engagement activities. And we defined low engagement as endorsing under 4 of the listed activities in the prior 3 days. We used the Ages and Stages Social Emotional Scale to evaluate child social emotional development, and we defined delay based on age-specific cut points from the tool. So just briefly, I wanted to explain more about the ages and stages evaluation. So this is a self-reported measure in which caregivers endorse child behaviors and affects relevant to the child's age group. And there are age-specific cut points for scores that indicate that further monitoring or referral may be beneficial to the child. Our study included 884 mother-child pairs with child social emotional development data for at least one visit between 30 to 60 months postpartum or post-delivery. The median maternal age during pregnancy was 26 years old, and 92% of mothers were married. Over a quarter of mothers experienced high adverse childhood experiences, and the most frequent of these was death of one or both parents. So 50% of people who had high adverse childhood experiences, that was the most common experience, was death of one or both parents. 1 in 10 women reported intimate partner violence in the 2 weeks prior to their pregnancy enrollment visit. And a quarter of mothers reported moderate to severe depressive symptoms during pregnancy. About 37% reported depression at least once from pregnancy through 9 months postpartum. And slightly over half of the children were female, 11% were preterm births. So high mother-child engagement, or having 4 or more mother-child engagement activities in the prior 3 days, ranged from 27% to 94% during the period from 24 months to 60 months postpartum. Engagement was lowest at 24 months postpartum, with a mean of 1.6 activities, and mothers reached peak engagement with children by 48 months postpartum. Singing to a child and talking to him or her outside were the most frequent types of mother-child activities. Telling the child a story was least common, yet it was still consistently high. So over 50% of caregivers told children stories at 30 months. Child social emotional developmental delay ranged from 4.3% to 26.6% during the period from 30 to 60 months post-delivery. Social emotional developmental delay was more frequent in earlier childhood at 30 months postpartum compared to later childhood or 60 months postpartum. So we also evaluated associations with low mother-child engagement. So you can see these relative risks in the middle column. And then we also looked at associations with number of maternal-child engagement activities, which is indicated by the coefficients on the right side. So mothers with less than 12 years of education were more likely to report lower mother-child engagement and a lower number of engagement activities compared to those with higher educational attainment. Mother-child pairs in crowded households were more likely to have low mother-child engagement and fewer mother-child engagement activities in the prior week compared to their counterparts in uncrowded households. And multiple psychosocial factors were associated with low mother-child engagement. Mothers reporting having higher frequency of adverse experiences in childhood were more likely to demonstrate low mother-child engagement, as well as fewer mother-child engagement activities. And mothers reporting intimate partner violence were over 25% more likely to have low mother-child engagement, and they also reported fewer mother-child engagement activities than women who did not report intimate partner violence. When mothers had experienced perinatal depression during any time in the perinatal period, they were more likely to engage in fewer mother-child engagement activities from 24 to 60 months postpartum compared to those who did not report perinatal depression. And there were no differences in mother-child engagement based on child factors of sex or preterm status. So we also looked at associations with child social emotional developmental delay, indicated by the relative risks in the middle column. And we looked at associations with social emotional development scores, indicated by the coefficients in the right column. So risk of social emotional developmental delay was higher among children whose mothers were married or cohabiting, and among those in crowded households compared to those without these conditions. Social emotional development scores were higher among children whose mothers reported more frequent ACEs compared to those reporting fewer ACEs. And social emotional development scores were higher among children whose mothers reported intimate partner violence during pregnancy compared to those not reporting intimate partner violence. And we saw a trend towards statistical significance for that same relationship in social emotional developmental delay. We identified a counterintuitive finding where social emotional development was less likely among social emotional developmental delay was less likely among children whose mothers reported perinatal depression compared to those without perinatal depression. However, we saw no differences in social emotional development scores among children by maternal perinatal depression status. And again, we did not see differences in social emotional development by child factors of sex or preterm birth status. And risk of social emotional developmental delay was twice as high among children with low mother-child engagement at the preceding postpartum visit compared to those with high maternal-child engagement at the preceding visit. And correspondingly, social emotional development scores were nearly 8 points higher among children with low mother-child engagement at the prior visit compared to those with high maternal-child engagement. And these relationships were even more pronounced when we compared mother-child pairs with 0 mother-child engagement activities in the prior 3 days. So we also evaluated potential differences in the relationship between low mother-child engagement and risk of social emotional developmental delay, stratified by maternal perinatal depression. And we identified a difference in the level of effect of low mother-child engagement on social emotional developmental delay by perinatal depression status. So among children whose mothers experienced perinatal depression, being exposed to low mother-child engagement put them at triple the risk of social emotional developmental delay compared to those exposed to high mother-child engagement. And among children whose mothers did not experience perinatal depression, being exposed to low mother-child engagement put them at twice the risk of social emotional developmental delay compared to those exposed to high mother-child engagement. So overall, we found that low mother-child engagement was more common among women who experienced perinatal depression. Low mother-child engagement was associated with twice the risk of child social emotional delay. And mothers interacted less frequently with children if they reported adverse childhood experiences of their own, household crowding, or intimate partner violence. And children with mothers who experienced ACEs, adverse childhood experiences, and IPV had higher risk of poor social emotional development. Our team feels that interventions addressing perinatal depression and those that encourage developmentally appropriate mother-child engagement should be integrated into mother-child health services and prioritized for those reporting adverse childhood experiences and intimate partner violence during the perinatal period. Thank you to my collaborators and to all of you for your attention.
Thank you so much, Dr. Lassen. I think we'll go directly to the next presentation and now talk about from the mothers and now to the adolescents. So we'll have Dr. Sarah Smugo talking about adolescent depression approaches. So Dr. Sarah Smugo is a research scientist at Kenyatta National Hospital. He has extensive experience coordinating pediatric and adolescent research, HIV research across the care continuum, which includes multiple clinical trials and implementation science projects in Kenya. His current research aims is to improve treatment outcomes for adolescents and young adults living with HIV, especially having mental health issues. So Dr. Sarah Smugo, your turn for your presentation.
Thank you, Dr. Ngomau. Okay, there we go. Sorry. I hope you have the correct view for my slide.
We're seeing it in presenter.
Okay, I need to swap.
Yeah.
Okay, there we go.
Yes, that's a correct view.
Perfect. Thank you all so much for listening to us. I'll make this brief presentation, looking at interventions for mental health. And this, what I'll be describing here, the study that I'll be describing, yes, is focused on mental health interventions for adolescents with HIV. We'll call it PROACT, and we'll tell you what PROACT is. But to note that we are looking at the integration of a transdiagnostic psychological intervention in the care for adolescents and youth with HIV, and I'll describe this terms next. Special mention to the principal investigators for this project, Professors Dalton Wamalwa and Muthoni Mathai, who are from the University of Nairobi, and Professor Pamela Collins from Johns Hopkins University. And my colleagues, co-investigators from Kenya and the US. Just a brief. You've heard this from the previous two speakers. There is a high burden of poor mental health among adolescents. It's quite significant, and although mental health illness tends to be chronic and tends to be cumulative, especially if you're talking about trauma, adolescent stages where we see a spike in a lot of these mental health conditions, where they're talking about depression or anxiety, and the burden actually increases, nearly doubles for the adolescents and youth with HIV in this age group of between 15 and 24. And this has consequences to their general functioning, consequences to their treatment, whether you're talking about HIV treatment or other conditions, and an uptake of basically good health measures that you could think of. So this slide basically summarizes the burden of poor mental health, thinking about any psychiatric disorder, anxiety, depression. You can see the range for this group of adolescents and youth with HIV is at least 25%. So at any point, you meet these adolescents, 25% of them may need your help if you're a mental health professional. And this has been, thought of, and the programs, both the HIV and mental health, divisions of mental health of the Ministry of Health have thought about this and appreciate this, which is why we have guidelines. We've got the HIV care guidelines being revised now, but we have the latest one being 2022 in circulation. And we also have the Kenya Mental Health Policy that runs between 2015 and 2030 with an action plan that I think lapsed either this year or something. Yeah, I think it's lapsing this year, the action plan. And for the adolescents specifically, we also have the adolescent package of care. And these guidelines, offer us a very good starting point. They give us targets, tell us that we need to have interventions for this population of adolescents and youth with HIV, and actually borrow from global targets, other global targets, where we say 90% of people living with HIV need to have to be linked or to be provided with people-centered, context-specific, integrated service. This is the call for integration so that everybody receives holistic care, mental health, and other NCDs. And they give a pathway. These guidelines give a pathway of what type of screenings should be done. First aid, mental health first aid, which usually will be psychotherapy. And for those with severe symptoms or symptoms that are progressing, they are referred to mental health specialists. But there's a challenge. These guidelines are there, but we've not been able to fully scale it, especially on the part of provision of the service. So the question has been, yes, you've advised us to provide some first aid and provide care within the HIV clinic, but what do we give as an intervention to these adolescents? Am I trained to offer mental health intervention, or what type of training do I have? Many people working in the clinic may have some counseling skills, but it's a little different from psychotherapy, which is what is recommended by the guidelines. So we now are offering to fill that gap with this project. Noting that psychotherapy has been found for many years, has been found to be the cornerstone of treatment of common mental disorders, including depressive illnesses, depression that is, and anxiety, and even trauma, PTSD and a lot of the other trauma entities. And for people living with HIV, we also know that you treat depression, you are very likely to improve treatment adherence and therefore treatment outcomes. And this sometimes, it sounds too emphasized. We might be emphasizing it too much, that you need to improve adherence, you need to improve adherence. But I think there's that emphasis because we know, on one hand, you don't take your medication, the consequences can be quite devastating. And if you take your medication, outcomes are very, very good, and you live a very long, healthy life. So the importance of emphasizing the things that help us take medication and maintain good HIV outcomes, I think, are relevant. And thinking about what interventions do we want to scale up or to test or to use within the HIV care setting. Just like any other very busy primary healthcare setting, you're not going to find patients and providers who have a lot of time to complete the long, very lengthy psychotherapy. And most of them may not actually need the very lengthy psychotherapy. And this has been shown in many other studies that were implementing long, very elaborate interventions that fewer sessions also have a good impact, and they can be good enough. So thinking about brief interventions, and we're thinking about adolescents who are going to school, who may have just started work, and they may not have a lot of time to come to clinic every 2 weeks or every week to receive a session. Probably 4 sessions, 5 sessions, 6 sessions may be good enough. And also thinking, what is this intervention? If a person has a certain disease, mental health disease entity or diagnosis, should they always receive something different from the one whom we find to have anxiety, from the one who we find to have some trauma symptoms? We generally find that there's a lot of crossover of symptomatology. So basically, the people who have depression, there's a good proportion that will have anxiety and also have the trauma symptoms. And so with this crossover of symptoms lends credence to the need for interventions that also cross over these diagnoses. And that is what now the field is doing, looking at testing psychotherapies across many diagnoses. And this is how, PROACT came about. PROACT was tailored from the trauma-focused cognitive behavioral therapy, which has been tested and found to be very effective with youth, with adults in the HIV setting, and so on. So we took 5, so this was piloted before this study was done, and among youth during COVID, with just 5 modules out of the very many modules of CBT, psychoeducation, relaxation, problem solving, behavioral activation, and cognitive coping. These are just some of the modules that you are taken through by a trained provider. And with psychoeducation, basically looking at tailoring the client needs, discussing and normalizing, mental illness and symptoms that they're feeling, and validating their feelings, because that's important as a place to start your psychotherapy. Relaxation for those who need it to learn how to recognize stress, and also learn how to relax and respond to the stress. Problem solving, this is work that has been done for a long time. It's been part of the HIV care for a long time. Problem solving frameworks where you define your problems and find solutions to them. Behavioral activation is more nuanced, but here you're looking at one of the big symptoms of depression, of course, is reduced engagement in normal pleasurable activities. And you want this person to now start integrating these pleasurable activities again to their routine. And cognitive coping, this is very, very impactful, where we learn how thoughts impact our feelings and cascade to impacting our behavior. So we've got many things, many stimuli that affect our thoughts, but we have the ability to actually impact what we feel, and then impact how we react to the feelings that we get. So we can change how we think so that we can respond better to external stimulus. And so, the intervention basically is targeting, gives you life skills, generally. But, thinking about the context of the person who has, depressive symptoms or anxiety or trauma symptoms, we are looking at, the intervention providing you with the skills. And hopefully with these skills, you can reduce your, mental illness symptoms. And of course, that impact, hopefully that impacts health behaviors and health outcomes. So this study has 3 aims. We completed the adaptation of this brief intervention by talking to multiple stakeholders. We talked to HIV care providers, mental health providers, specialists, policymakers, managers within the clinics, and so on, so that we can get just the right intervention addressing the most relevant issues that adolescents and adolescents too, to note that they were heavily involved in this adaptation. And we got a package that now we moved into aim 2, where we are currently doing the evaluation of effectiveness, and also looking at how to implement it for these adolescents and youth between ages 16 and 24. And we are also collecting data to determine the cost effectiveness as we are doing this evaluation. So this is how the intervention looks like. We are calling it PROACT based on the 5 modules that I talked about. We are doing mostly in-person, one-on-one delivery, but also allowing for phone delivery for patients who may need to move out of their primary clinic. For example, move from Nairobi and they're transferred maybe because of work and go to Homa Bay or something like that. We are doing phone delivery too for those. There is many people have asked options of group therapy, but we're not doing group therapy for this particular intervention. Who is delivering it? We trained non-specialist providers in the HIV clinics, and they are under supervision by trained PROACT providers. Many of them have trained in psychology, and they're the ones who, for every session, they provide some supervision before the session and after the session to the non-specialist. And what do you mean by non-specialist? It means your clinical officers in the CCC, your nurse, your medical officers, your peer educators, and so on, people who are not mental health specialists. And yes, we are targeting the 16 to 24 years with screening, and we'll discuss that in the next slide. And we enroll them, and for those in the intervention sites, we include them in the intervention. So the session usually will last between 30 to 45 minutes, and generally you will get about 5 sessions. Some will get a little more, maybe up to 8 sessions if they have a lot of distress. So some of the things that we have learned, previously is the strict time, cadence that we provide to add, the patients to come back to clinic, come every week or come every 2 weeks. It's not possible with the adolescents because they're in school and they have to do other things. And so you probably will have to match their mental health appearance for the sessions with them coming to other clinic visits. And yes, we are targeting depression, anxiety, and trauma. And this is the trial design. We are running this study in Nairobi, Kisumu, and Homa Bay counties. Both the 3 counties, we are taking 10 clinics, a total of 30 clinics. 15 of them were randomized to intervention, and 15 of them to control sites. We are screening adolescents using the PHQ-9, and also assessing suicidal ideation. And for those who have symptoms, we, in the intervention sites, go ahead and receive the proactive intervention. Those in their control sites only receive the standard of care. So I use the word only, but they do receive whatever the clinic can provide. Some clinics do have ways in which they are able to do structured counseling, but they don't receive psychotherapy like the control clinics are doing. Our primary outcome are these PHQ-9 scores assessed at month 3, month 6, 9, and 12, with month 6 being the most important outcome, and month 12 looking at maintenance of treatment. Secondary outcomes are looking at anxiety scores measured using the GAD-7, and trauma scores assessed using the 2 scales, the CATS. The CATS is used for under 18s, and the PCL-5 is used for over 18 and above. And we're also looking at treatment adherence and looking at the viral load impact of the intervention. And I've talked about this. For the suicide, I didn't mention that. We're using the Ask Suicide Risk Assessment. And these are the scores, basically, just saying, these are our cutoffs for what we are considering, severe depression, which is just as is known for depression. The PHQ-9 is a score 20 and above. So we've collected quite a bit of data over the last 8 months, and we've as of April, we had visited in the 30 clinics. We had come across 2,700 adolescents, but we are only able to approach 1765 and screen 1337. So basically, we are going to miss some because some will be in a hurry and they'll not want to wait for to be approached about the study. And those who are eligible were about 458, and we were able to enroll 417, targeting to get to 600 by August. And we have quite a bit of variability in screening across the sites. So we have clinics, some of the clinics, very high screening rates, like Kayole or Kisumu, it's 84, 85. And some of them are very low, like Ahero, where it's 18. It's improved quite a bit over the last few weeks, but that's the case that we are seeing. There's quite a bit of variability in that. And so whom have we basically screened? An adolescent, this is basically a young adult, a median age of 18, mostly female, as is the characteristic of a lot of adolescent HIV clinics. And most of them are in school, 64% are in school, and just a few of them are actually in boarding school. One thing we noted is that close to 45% are actually not in any support group. And that's an interesting one. And only about 10% report feeling unwell or reporting health being poor. And also to note that there's a very high rates of unemployment, even for those who are out of school. So this is a significant other stressor that we've got to consider. And close to more than 50%, more than half, have lost a parent, whether single or double orphanhood in this case. So what is the burden of depressive symptoms? We are seeing at least close to 35%. As we continue recruiting, we're seeing the burden go a little higher. So it's about 35% right now of at least mild depressive symptoms. And close to 15% of those have some suicidal thoughts, whether it's just fleeting for a few days or very persistent. And this, people who have, among those who have some depressive symptoms, close again to 15% of them have current suicidal thoughts. So they've got plans right now of committing suicide. So this shows that the burden is real. It's quite significant. And again, there's this variability across sites. Where we'll see some sites like Migosi in Kisumu, more than half of those we screen have some depressive symptoms, and on the other side of the county, Chulaimbo, only about 18% show these symptoms. So it's really not about the county, but in our analysis, we'll try and tease out why we are having this huge variability in depressive symptoms. And there's comorbidity with anxiety and trauma. We are seeing, because this cohort now, basically, all of them have some mild or moderate or severe depressive symptoms. Among them, we are seeing that, about 60% or 65% have anxiety symptoms. And so that's quite significant. There's significant comorbidity between anxiety and depression, and that is expected. That's something that we expect. And when you look now at trauma, we are seeing between 25% for the younger kids, and as is expected, we are seeing 33% for the older kids also having comorbidity with trauma symptoms. And this is expected, of course, as you grow older, you accumulate trauma. And this is significant that we also have to deal with trauma symptoms for these adolescents. Yeah, and what are we seeing with treatment adherence? Basically, the baseline, poor adherence is quite a significant problem. Only about 58% report that they did not miss any doses over the last month when we enrolled them, and significant, more than 10%, actually close to 15%, do report that they've missed at least 3 doses of their medication, and that is significant when it comes to HIV treatment adherence. We have pretty good retention within the sites into a study, because we'll follow up these adolescents for a whole year. We have good retention for those people who require the intervention in the intervention sites, and for our assessment of outcomes, which is ranging anywhere between 80 and 93%. So what are our next steps? We are hoping to complete enrollment by the end of August, and hopefully we will continue with the study and continue complete follow-up 1 year after for those who will be in the study. And also start post-trial implementation research. So asking questions like what worked, what did not work, what are the reasons why the things that worked did so, what are the factors that did that, and we'll do interviews, and we will do surveys and so on. And we'll also do analysis for costs so that we're able to inform potential scale-up of this intervention. Thank you very much. I hand it back to you, Nancy.
Thank you so much, Dr. Mugo, for your presentation. It's throughout, I think all the presentations I've been seeing reactions, people clapping, people putting a thumbs up about this, and I guess it's of interest to everyone. As we continue, I'd request you type in your questions if you have in the chat, even as I go through the questions that have currently been asked. So there's a question from Dr. Anne Wawire, and so there's this notion that once mad, forever mad, a community attitude. She's asking that we explain. Maybe I can ask, I can begin and then ask any of the presenters to also chime in. When we're talking about mental health advocacy and omission of lived experiences, I think this is one of the lived experiences that people who go through, who have mental health problems or mental health illnesses have within their communities and within their setups. Several papers have been published that say that that it's severe, even when you have severe mental health illness, it's not always lifelong. And even if chronic, there's ability to be able to contribute to the society and ability to live satisfying lives within the community. But then in our setting, and I believe in all other settings, there's that notion or that fear or that stigma that exists that once, well, I guess even just saying mad is stigmatization of people with mental health illnesses or mental health problems. So this notion is not true based on evidence that's there. But then it is up to us to change this notion so that people with such lived experiences are able to contribute to society, inculcate it in policy, and just get financial support for this work. Maybe Anna or Dr. Mugo, if you have any further response. And I'm putting the paper on the chat so that everyone can see.
Yeah, I think I can just chime in. The biggest reason why people say, you get, mental health illness, you always have it. The big reason is because very few people actually access services. It's I'll have to pull the paper too and just post it to show you. WHO estimates that 75% of people in low and middle income countries with severe, not just any, severe mental health illness never get diagnosed or treated. And, other studies that have been done, especially in Western Kenya, the Moi team, looking at, community level prevalences of poor mental health, they show staggering numbers. 50%, 60% of people are experiencing this and are not receiving any care. So it's one of the highly neglected conditions. And the way to change the community, feelings of once mad, always mad is basically offering services and offering them from, very mild, having interventions for that available until, you have the severe where you have whether it's hospital-based or other forms of care that can be provided. Yeah, thank you, Nancy.
Yeah, I definitely echo what Dr. Nancy and Dr. Cyrus have said. I'll just add another bit of insight on the perinatal mental health perspective from some research that our colleagues also completed. So I think thinking about perinatal mental health is a good way to kind of debunk this community notion of once mad, always mad, because we know that there are individuals who, when they're not pregnant or postpartum, don't experience mental health symptoms and then do during that period. So there's definitely something going on hormonally, lifestyle wise, that's contributing to mental health symptoms. And we also know that during the perinatal period and after the perinatal period, there's also a portion of people who have experienced mental health challenges during the perinatal period, but those resolve at some point during that period or after. So, so just thinking about that as a case study, an example, kind of helps to debunk this. But I definitely agree with the points that Dr. Cyrus made about access to services and utilization of services, and the fact that that has been historically and traditionally low, kind of helps these notions to persist. And also agree with Dr. Nancy's statements that the best way to kind of quiet the voice in the community that's propagating stigmatizing ideas like this is to improve advocacy and just talk about these issues more.
Thank you so much, Dr. Lassen. I'll combine a few questions directed to you, Dr. Mugo. And this is about PROACT and the activities that happen during as you're doing PROACT. So Penina is asked, okay. The first question is the intervention session with a parent. Is that with the youth or separately? And what's the timing, at the beginning or at the end? And then what do you do with those adolescents who are found to be suicidal? And the last one is the issue of urban versus rural variation. Maybe you can explain why that would be the case, particularly when you're thinking about Chulaimbo versus Migori.
Okay, so yeah, I can start with the first one, thinking about the parent. So this so we've made this provision and we do tell the adolescent, because we start with the adolescent. So we screened you and you could benefit from this intervention. Some of them come with the parent, have the parent with them, and they will say it's fine to have my parent in the first session. Others will say, I really don't need my parent, it's fine, they can go home and I can be left doing the session. But we do offer this session to the adolescent. We are offering the session to the adolescent. Can we have your parent have this session with us? And we've actually not had an adolescent that we need, who has said, I'm okay bringing the parent. Even where the adolescent expresses that the parent could be part of the risk that they are experiencing. We've actually not experienced that. And probably as we go, I mean, we're not even halfway through the intervention. So as we go along, we probably might experience more adolescents asking for parents to come in. But it would be offered ideally separately, or if the adolescent wants them to be together, then that's fine. And this would also orient the parent to what is being done. So yeah, unfortunately, I don't have a lot of experience with that right now. So the other question was, sorry, I think I forgot the other question about the suicide cases. Yes, so these are being treated very seriously, and they're being, referred to either a psychologist or psychiatrist right away. And we are facilitating that as a study to ensure that this referral and linkage with a specialist is made. Many of them, we've had quite a number, and many of them have responded very, very well to the referral. And when they come back, if they're in the intervention sites, they receive the intervention that we're getting, and they're also expressing a lot of optimism and acceptance of this intervention. Rural versus urban, we've actually not looked at whether there are differences, and it's deliberate because it's a clinical trial, and we do not want to bias how we are doing either the recruitment or follow-up. So we really don't want to make critical analysis at this point in the middle of the study that could bias how we conduct the study. Thank you.
Thank you so much. There's a comment from Lois Okello that says that they still hold the view that the mental health fraternity has not fully involved counselors and psychologists who are across the nation with a better presence than psychiatrists and clinical psychologists. And I think throughout this conversation, that is what is being brought out that we have, yes, the psychiatrists, we have psychologists, but then how do we involve everyone to be able to either offer service or to advocate for ways that services can be offered, so that someone somewhere and everyone has gets the service, because within our setting, access to service is difficult. And as we've just had from PROACT, we are seeing that that's one of the interventions that are happening. So now for adolescents, there's the intervention where you train people on the psychotherapies, and then that is then given and just extending the hand to everyone. Just also to highlight, there are currently studies that are ongoing. There's a study that is ongoing that's trying to see, is it possible to offer stepped care to perinatal women, where we have, again, mentor mothers, HTS providers, doing the initial screening for mental health among the pregnant women, and then seeing whether they can get psychotherapy, HIV HTS counselors and the mentor mothers, and then step it up for those who have severe symptoms, get telepsychiatry. And I think the question again boils back to what I said in terms of the mental health advocacy. What is our ask? Everyone here is a healthcare provider in a different light. So what is your ask? In the community you're in the context you're in, the proximal context, what do you see that may work? What do you see may help in terms of delivering services, in terms of instituting this, and just trying and seeing what we can do? But then it is true that as the medical fraternity, we've not fully involved everyone in this. Any comments from the panelists before I continue?
So I think the only thing I could add is, the psychologist, yes, I think that is where the first line of, whether it's mental health education or mental health, treatment, or even other interventions that may come in between. Really, the psychologists are a backbone to that, because we have very few psychiatrists, and mostly they will be in the treatment facilities. So yes, I do see a place for that, and I know there's the question of why are you going for non-specialists when there's this big psychologist group? And for us, you look at the structure and see who is available within the clinic. And these people should be utilized within the clinic, but at the same time, equip everybody else within the clinic setting to provide basic mental health services.
I echo what both of you have said, nothing to add.
So a few questions, even as we almost wrap up. This question, I'll direct it to you, Dr. Lassen. The issue of IPV, particularly in the perinatal space. We have mothers pregnant, breastfeeding, who have who experience IPV and contributes to perinatal depression. The concern that is being brought out is that that is not screened, and that is not identified, referred. So how do we train more staff, or what do we do to be able to address it? And then a question also after that to you, Dr. Mugo, from Roslyn Mkabana, and she's talking about preparation for adulthood curriculum. You've talked about the PROACT curriculum that you're implementing. Is there a possibility of inculcating other curriculums, like the preparation for adulthood or peer support, or other interventions that will be able to support the adolescents that you're working with?
Thank you, Dr. Ngumbao, and thank you for this question. I think this is a really very important area. So thinking about co-occurrence of perinatal mental health challenges with experiences of intimate partner violence. And as you saw in our work, that was very much present in this cohort. So yes, I fully agree with this question about the importance of integrating screening for intimate partner violence as approaches to screening for mental health challenges are expanding in the region. I think this is an important aspect. And of course, even beyond mental health topics, intimate partner violence is a stigmatized area and really challenging for people to bring up. It requires a lot of trust with the healthcare provider to do so. So I agree that I think there's a place for screening here. And I also think it's about training mental health providers on kind of the range of stressors happening in individuals' lives and kind of how to appropriately probe into those areas and discuss problem-solving strategies. And also just normalization and validation, as Dr. Mugo highlighted, is a really important aspect of psychoeducation and psychotherapy. So just, normalizing that this is something that occurs and validating that it is extremely stressful and helping individuals problem solve the situation. Another aspect that I'm interested in and colleagues in the panel are interested in is thinking about, in addition to, specifically for the perinatal population, in addition to supporting perinatal mental health, is also thinking about male partner mental health and how are we reaching men to improve emotion regulation and men's problem solving skills and addressing men's mental health issues, which may be underlying some of the expression of intimate partner violence. So I think there are opportunities to get at this issue in multiple angles. And similar to mental health, I think it's about advocacy and destigmatization and just recognizing that this is an experience that needs to be addressed in the community. Thanks for that question.
Thanks, Dr. Larson. And I think the question that was directed to me, yes. We definitely would not advocate for offering mental health interventions in isolation. Of course, in a clinical trial, we've got to do that because we need to, establish efficacy, and tell people, this is how this works. But in real life setting, incorporating all these interventions, whether it's parenting interventions or other very useful interventions, do impact mental wellness eventually, and so are appropriate to combine with these brief interventions. The question, of course, is the capacity of the people being trained to offer these interventions, of course, and time to deliver them. And that's a major implementation question that we are dealing with currently in our study. And many of the studies being done, it's always a question, yes, we can do so much, but as a primary care provider, I don't have time to. In the OPD, I want you to provide these services in the OPD. I want you to go to the community health providers, the volunteers and so on. We want them to provide these services, but how much time do I have to interact with one patient? And so what are the things I can give? So those are the considerations, basically.
Two questions, and I think then we can be able to close. 2 to 3 questions. I guess the first question also is to Dr. Larson. So how do we handle perinatal depression? How should that be handled? Right now, what happens is sometimes the neonate is taken away from the mother because the mother has mental health challenges. The mother is referred to a mental ward. How should we handle perinatal depression, and in the wake of advocacy, what can be done? And I guess the larger question that I'm finding interesting is, we've talked about different populations, the adolescents, the pregnant women, and Joyner is asking, what about healthcare workers? What do we do for healthcare workers? We experience the mental health problems, mental health issues, and we fear to get help from our colleagues and from people that we know. So what do we do?
Great, I'll address the first question. So again, thank you for this question. I think it really speaks to the extent of stigmatization and the harms that stigmatizing mental health can bring in cases where women are maybe separated from their child as part of treatment. And as you saw in the research I shared today, there's such an important it's so important for mothers and children to develop attachment, especially early in postpartum. And so, as much as possible, treatment approaches for perinatal mental health that don't separate mother and child is really important. Although there are some unique cases where, a mother's mental health challenges may be at such a severe level that she may be posing risk to herself or her child. And so those cases, while rare, should be treated to optimize the health of the mother and the child. But I think what this question is really getting at is how do pregnant or postpartum women who are experiencing mental health challenges bring those forward to a health provider without fear of an escalated and potentially traumatizing treatment experience. And Dr. Ngumbao talked about a study that our colleagues are conducting now, which is evaluating a stepped care model for perinatal mental health integrated into mother, child, and HIV care services. And the approach that she described is really kind of triaging individuals based on the severity of symptoms. And we know that the majority of perinatal women experiencing mental health challenges will just need, some lower intensity treatment, psychotherapy. And so in our study, those women are receiving Problem Management Plus, which is a psychotherapy kind of similar to the one that Cyrus mentioned from his study. And so for the majority of women, that will be very supportive and helpful for resolving some of those symptoms. And then in our study, again, for women with higher severity symptoms, they will be also provided telelinkage to mental health specialist care provision, and potentially that may include psychopharmaceutical medication. And so that's the approach that our team is pursuing and thinks would be feasible and acceptable within the Kenyan healthcare system, and we hope would reduce some potentially harmful treatment practices. I hope that was helpful.
Yeah, I think that was great. I think maybe lastly the question that was posed regarding the safety. So it's a question of safety. So our hospitals equipped to provide care for a mother-child pair with a mom who has a mental, maybe severe peripartum depression. And the question is, no, our public health sector is not equipped for that. We do not have enough staff within those spaces that could, and that is really just a question of, do you have the person there who can take care of these two, and the personnel to also deal with the mental health issue for the mom? How stretched are they that they are able to come to that maternity or the ward that the mom is in, or neonatal ward that the mom and the child are? And so it's a big health system question there that will answer a big mental health injustice. Thank you.
Thank you so much. I think there's a question on healthcare workers and what to do. I think this becomes a question for us. What do we want? How do we tailor what we want? Again, and throwing back the question back to us. I think part of the solutions lie with us. And some of the studies, like the PROACT or the study on stepped care for perinatal women, those are, they come up when we're listening to the perinatal women or listening to the adolescents. And as Dr. Mugo was saying, even for the adolescents, their care is structured differently because that's what they need, that's what they want. So I guess the question remains back to us in terms of what do we want as healthcare workers? Thank you so much for participating in this webinar. We have come to the end of the webinar. Thank you for the questions. Thank you for listening in. For the guys in Kenya, it's late on our end also, so thank you so much. Thank you to our panelists for the presentations. Maybe any final comments from Dr. Lassen and Dr. Saras?
I'll just echo Dr. Ngumbao's call to action for everyone on this call as healthcare providers to be the front line for advancing mental health and destigmatizing mental health in your communities and contexts. Thank you all for the work you do.
And thank you too for having me. Thank you so much, team. Yes, a call to action. Let's make mental health services available to all of us. Thank you.
Thank you so much. In the background, I hope you've been seeing what has been prepared for us for the Mind Week. This week we are talking about the mind, all aspects of the mind. Tomorrow, Thursday, we will have further engagement, talking about further engagement interventions and influence on maternal and child health. I know those questions about what about the fathers. So Thursday, tomorrow, same time, we're talking about the further engagement. Friday, same time, we're talking about neurodevelopment assessment approaches and intervention. So stay tuned. Kindly keep joining, keep with us for this Mindweek Symposium. And thank you so much. Have a lovely day or evening.
Thank you.
Thank you.